And hopefully you all can see that. So good afternoon, everybody. Wanted to kind of kick off our conversation and talk a little bit about telehealth today. In particular, I just wanted to do a brief overview of today's webinar in terms of outlining kind of some of the goals that I hope that you will all receive today. First, I would note that we're going to talk a little bit about Massachusetts' current telehealth law and reimbursement landscape. Secondly, we're going to talk a little bit about some recent research and recommendations from the state's Health Policy Commission regarding the utilization of telehealth during the pandemic and its impact on costs. Next, we're going to talk about some legislation that's been filed in Massachusetts to address issues regarding reimbursement for telehealth, interstate telehealth practice, and digital equity. We'll also discuss some kind of breaking news with regards to recent proposed rules from the federal government regarding the prescribing of controlled substances. And we'll talk a little bit about steps taken by the federal government to extend certain Medicare telehealth flexibilities beyond the end of the federal public health emergency. So a little bit about tMED, the Massachusetts Telemedicine Coalition. The tMED Coalition was started in 2015 and currently represents more than 50 provider organizations, consumer advocates, technology organizations, and telecommunication associations, all of which are united to help support the advancement and expansion of virtual care here in Massachusetts. The goal of the coalition is simple, really. It's to advance and expand the access and use of telemedicine in Massachusetts. As we said, it includes providers, consumers, technology providers, and telecommunication associations as well. And a little bit about the tMED Coalition to think about as well. We started in 2015, but Massachusetts pre-pandemic had a very limited use of telehealth. There was a limited law on the books for commercial payers that was implemented in 2012, but telehealth through this law was only allowed in insurer-approved telehealth networks, so on a very limited basis by commercial insurers. The state's Medicaid program did not start reimbursing for telehealth services until January of 2019. And I would note that they only started reimbursing for services for behavioral health services at that time. So pre-pandemic, Massachusetts was in a very limited environment, particularly for the utilization of telehealth. And pre-pandemic, in terms of advocacy, our tMED Coalition was only seeking 3 major policy issues to advance telehealth, and only at the state level. And I would say that Massachusetts was kind of late to the game in terms of its advocacy with regards to telehealth. So back in 2015 and really through the beginning of the pandemic, the 3 key pillars that we were working on with regards to telehealth were coverage parity, insurance coverage parity, for all payers, including the state's Group Insurance Commission and MassHealth and our commercial payers, not reimbursements parity, simple coverage parity for telehealth services. Secondly, we were asking for that there be proxy credentialing to reduce the paperwork burden associated with providing telehealth. And when we say proxy credentialing, we're really talking about credentialing between institutions. We're looking for credentialing of, say, a physician who may be located at a downtown Boston teaching hospital that's providing care to a patient by way of telehealth, perhaps at a facility in Western Massachusetts, and they would need to be credentialed at both facilities under kind of previously existing rules. And what we asked for as part of this legislation was that they could be proxy credentialed at the facility so long as they had received the full credential at the kind of the major academic teaching institution where they may be practicing. And then lastly, one of the key pieces as part of the Telemedicine Coalition, and I think it's still important today as we continue advocacy in this space, is we wanted to make sure that the definition of telehealth is flexible yet comprehensive, and includes not only interactive audio-video technology, but also asynchronous technologies, including e-consults and remote patient monitoring. And it's important to point out that previous and prior to the pandemic, advocacy left out the use of audio-only telephone, which is something that's changed significantly during the pandemic. And obviously, audio-only telephone is used and covered very frequently now. And it's been a resource, especially for those who have not had access to audio-visual services. So I think that's a really important piece to kind of talk about and what was going on prior to the start of the pandemic. But the pandemic created great opportunities for the use of telehealth. And in particular, I think we would note that, commercial insurers and Mass Health were required to cover telehealth services because the governor had issued an executive order as part of the public health emergency, and this included the use of audio-only telephone. That was extremely helpful for the expansion of the use of telehealth. And I think it's really important to remember as well is that the Secretary of Health and Human Services at the time in the Trump administration specifically said that Massachusetts was one of the highest utilizers and adopters of telehealth during the initial first surge of the pandemic. Secondly, what was really helpful, important in all of this is that insurers were not able to impose any specific requirements on the technology used to deliver telehealth. And I think it's also important here to kind of mention as well is that the federal government was extremely instrumental in this space because they essentially indicated that I would say almost a HIPAA waiver was in place, and you could use virtually any type of platform for the use of telehealth, and it did not have to be kind of a HIPAA covered platform because we wanted to make sure that we were able to deliver telehealth as best we can and whenever we could. So you were able to use a lot of things like FaceTime and Facebook and other types of kind of platforms previously that wouldn't have been allowed to be used. And once the public health emergency ends now, will not be allowed to be used unless they are HIPAA compliant, which I think is really important. Thirdly, as part of the pandemic, insurers were required to cover telehealth services and reimburse them on par with in-person visits, an extremely important piece of this puzzle. And finally, there was no prior authorization for telehealth unless that prior authorization was also required for the same service when it's delivered in person. So that's an extremely important piece. We'll talk a little bit more about that in the future, but that's also an important piece in terms of the use of telehealth and the use of telehealth moving forward. So telehealth was used during the first year of the pandemic. We had legislation pending in the legislature to create a regulatory framework with regards to telehealth that we had continued to had been promoting since 2015. The legislature at the very tail end of 2020 passed legislation to kind of put in place that legal framework for telehealth. And that is Chapter 260. It's an act promoting a resilient healthcare system that puts patients first. And as we said previously, it had those three pillars that we were looking for. So there's coverage parity across all payers, including for Mass Health and the Group Insurance Commission, essentially state employees. The telehealth is defined as both synchronous and asynchronous technologies, including e-consults and remote patient monitoring. And it also includes audio-only telephone. And then third, it also permits that proxy credentialing process for telehealth services, as we had explained previously, to help us reduce the administrative burden of providing telehealth. In addition to those three pillars, there are additional pillars that are extremely important as part of the passage of this legislation. First, the legislation provides permanent reimbursement parity for behavioral health services. Extremely important component of this legislation from an area and a particular area that has been, kind of underfunded previously and gives them kind of that permanent reimbursement parity for behavioral health. Secondly, it provides 2 years of reimbursement parity for chronic disease management and primary care services. And that reimbursement parity just ended as a mandate as of January 1st of this year. So far, only one insurance company has decided to reduce reimbursement since that reimbursement parity mandate is not in place right now. So still good news, but we'll talk a little bit more about that kind of a little bit later in the webinar. Third, as part of the legislation, it assumed reimbursement parity for all other telehealth services through the end of the state public health emergency. And then they had a little bit of a grace period for 90 additional days after the public health emergency ended on September 13th, 2021. So that was a key component of this as well. And then finally, the state's division of insurance has to implement regulations with regards to accreditation of insurance companies and how they provide access to telehealth services. And we'll get into that a little bit more as the webinar goes on. The bill also had really important consumer protections that were kind of critically important in terms of and kind of follow frameworks that we've seen in other states with regards to telehealth. There are network adequacy provisions that are included in the legislation that make sure that you are able to ensure access to in-person visits. I think there is a strong belief that they do not want insurance companies over-relying on telehealth, and they want to make sure that if a patient wants to receive services on an in-person basis, they should be able to do so, and the insurer should have adequate networks to be able to provide those services. Secondly, there should be no documentation of any barriers to an in-person visit in order to justify the use of telehealth services, which is something that's been kind of implemented in other areas in other states, and this is something that's a key safeguard kind of out there right now. Third, there should be no limits on the type of setting where telehealth services can be provided, extremely important piece. And patients who are receiving services can decline receiving services by way of telehealth in order to receive services on an in-person basis. Again, a safeguard for those who are maybe apprehensive about the use of telehealth and want to be able to receive services on an in-person basis. Additionally, copays, coinsurances, and deductibles for telehealth cannot exceed the same out-of-pocket costs for in-person visits, an extremely important safeguard. And finally, standards of care for telehealth are the same as for in-person services from a provider perspective, which I think is an extremely important safeguard for patients as well. During the public health emergency, we also wanted to kind of point out some of the provisions that have been available to folks for coverage and reimbursement with regards to telehealth. In particular, there's been coverage and reimbursement provisions that the Mass Health program put in place that require telehealth to be covered and reimbursed on par with in-person visits until September 30th of 2023. Audio-only telephone is included and required under the Mass Health program. Coverage for remote patient monitoring was introduced for COVID patients during the public health emergency. One of the things that I think is extremely important to be mindful of is we are awaiting a permanent coverage policy for remote patient monitoring from the Mass Health program. They've told us that it is imminent, but that's been imminent for quite some time. So hopefully we'll hear soon from Mass Health regards to the coverage for remote patient monitoring. Additionally, the Mass Health program here in the state recently issued a bulletin that announces coverage for e-consults or interprofessional consults, which is extremely good news. It's something we've been asking for quite some time, and we're glad that the state has now adopted those policies. And one of the things that we'll talk about a little bit later as well is that prescribing of controlled substances is permitted without an in-person visit following the federal and state guidance that's come from the Drug Enforcement Agency. I note here that this may change soon, but it's not going to change as soon as we thought. So that's good news. Additionally, I think it's really important for folks that are on this call to be able to keep an eye out. The state will probably be issuing a bulletin on the coverage and reimbursement of telehealth in the Mass Health program post September 30th, 2023. So we're eager to hear about what the next steps are that Mass Health will be taking with regards to telehealth and coverage and reimbursement. Obviously, it's been going very well for Mass Health thus far and for their patients. We hope that the current coverage and reimbursement policies stay in place. We've asked for that through legislation, and we'll hope that these coverage and reimbursement policies will continue. I wanted to kind of just talk for a little bit too as well about what the current reimbursement landscape looks like here in Massachusetts. And I alluded to this a little bit earlier, but it's really important to point out that while the mandate for reimbursement parity for telehealth services for primary care and chronic disease management did expire as of January 1st, only one insurance plan, Point 32 Health, which includes Harvard Pilgrim and Tufts, has implemented a reduction in reimbursement for telehealth for primary care and chronic disease management, which is a 20% reduction. On the good news side of the ledger, Blue Cross Blue Shield of Massachusetts indefinitely postponed their plans to reduce reimbursement for telehealth services And to our knowledge, no other plans have taken any further actions to date. So that's kind of coming from the good news side, but it is a little bit confusing, and there's a little bit of uncertainty from providers as kind of, and as I go through this presentation, you kind of hear that uncertainty is we need that predictability. And I think that's extremely important kind of moving forward with all of the use of telehealth. And then I alluded to this a little bit earlier as well, is under Chapter 260, the states and telehealth law, the state's Division of Insurance and its Bureau of Managed Care is required to put forth regulations to establish minimum standards for the accreditation of insurers. And this includes, kind of what insurers are able to do in terms of access for behavioral health services, those chronic disease management services, and primary care services that are delivered by way of telehealth. And they have to consult with the state's Health Policy Commission and the Center for Health Information and Analysis, which are the two state agencies that were created back in 2012 to kind of monitor and advise on the state's healthcare policies. This is the kind of one of the sticking points that's still out there, and we'll talk a little bit more about it. So the state's Division of Insurance has done a really comprehensive job in terms of asking for further information from stakeholders in the community. They held a series of information sessions back in the spring of 2021, and they focused on these specific issues as they're thinking about these regulations. They want to understand carrier communications with members and their providers. They want to understand how insurers are doing contracting with healthcare providers for telehealth services. They wanted to have a good understanding about those telecommunication platforms that are out there and HIPAA compliance with platforms and what that means for access for patients. They were very interested in terms of what constitutes a telehealth visit. It's an extremely important component that people are very, very interested in, and how you define a telehealth visit. And what that means for cost sharing for patients. And they were very interested in, if you may be on a phone call and you have a phone call with a patient and it converts over to a telehealth visit, what information do healthcare providers need to be providing to patients to make sure they understand what their cost sharing liabilities might be? Additionally, and this is extremely important from a reimbursement parity perspective, they wanted to understand how we should be defining services, especially chronic disease management services, behavioral health services, and primary care services. In particular, I would note that CMS has a definition for chronic disease management services that is very limited in scope, and it does not cover pediatric care. And I think that's an extremely important piece in all of this, is it doesn't cover many of the pediatric diseases that are considered chronic in nature. Additionally, the state, when they crafted the legislation, they put in an expansive definition of behavioral health services that also includes developmental disability services. So it's extremely important because we want to understand what services may be covered as behavioral health services, in particular, noting those patients who may have autism or Down syndrome and may be covered through these services for certain kind of developmental delays in particular. And finally, we also know as well, we need to kind of have an expansive sense of what primary care services are, in particular, noting many of the maternal health issues and kind of those providers who provide maternal health services and how they should be considered as primary care services. And that's just a slight definition and kind of toe dipping in the water of what kind of all the kind of concerns over the definitions of the rules for services are. And the Division of Insurance is very interested in that. Additionally, the division is very interested in kind of what the rules for reimbursement should be, but they are kind of also at the same time, they have to live within the strictures of what the statute says. And so any changes with regards to reimbursement or reimbursement parity have to be handled at the legislative level. One of the things that the division is very interested in with as well is how should providers bill for services and what do they need to tell patients when they bill patients for services, how utilization review and prior authorization should be handled for telehealth, and also what kind of telehealth standards should be in place for managed care accreditation reviews for insurers. So just a small sample and smattering of kind of what the Division of Insurance is interested in. So right now, in spite of the legislation being passed in January 2021, and the series of listening sessions that were held by the Division of Insurance in spring of 2021, They put forth proposed draft regulations at the in the spring summer of 2022. They held public hearings, and now we have had a subsequent change in administrations. So we are patiently waiting for the Division of Insurance to release final regulations on telehealth. And so that's kind of, we issued, I think 11 pages of comments with regards to the draft regulations and submitted more than 28 pages of comments when the Division of Insurance had listening sessions way back in 2021. So kind of in a wait and see mode at the moment. And we're always having conversations with the Division of Insurance about when we should be expecting additional guidance from them. To take it in a different direction for a second, I also wanted to mention the state's Health Policy Commission, which is directed by the legislature back in 2021 when they first passed Chapter 260. They put in place language that directs the state's Health Policy Commission to conduct a study on telehealth use and to provide policy recommendations on reimbursement levels and strategies to expand access to telehealth in Massachusetts. What they found was fascinating in my mind. In 2020, 31% of all ambulatory visits in Massachusetts and 65.6% of mental health visits in 2020, in the midst of the pandemic, were conducted by way of telehealth, with about 53.5% of all commercially insured members in Massachusetts making use of telehealth for at least one visit. They noted, and when the Health Policy Commission found that telehealth use was higher for patients with more chronic conditions in more urban communities and for those with better internet access. Yet there were minimal differences by community income level. And perhaps I think the most important takeaway and finding from the Health Policy Commission's report is that, especially in this environment in Massachusetts where cost is such a significant concern, is that the Health Policy Commission found that expanded telehealth use did not increase total spending, while the availability of telehealth also appears to have improved access to mental health care. So two big takeaways there, but one that's extremely important with regards to telehealth not increasing total healthcare spending. It is substitutive in nature, not additive. So the Health Policy Commission has subsequently put forth recommendations based upon the January report. And I think the most important recommendation in particular is that they do recommend extending payment parity for certain high-value services. In particular, they want to extend the sunset for payment parity on a limited basis, perhaps for 2 years, for primary care and chronic disease management. And through this extension, it would allow for additional time for providers to provide and improve their telehealth platforms and improve their telehealth workflow and develop efficient hybrid care models, because really that's the environment that people are practicing in now. Predominantly, they're now back to providing in-person services with some telehealth that's being provided, maybe some 15 to 20% in some practices, perhaps a little bit higher and much higher in behavioral health practices. But for the most part, folks are back to kind of a hybrid care model that takes advantage of the lower resource needs for some telehealth visits relative to in-person visits. Additionally, the Health Policy Commission did recommend that there should not be unnecessary hospital fees. They recommended reducing telehealth billing complexity, in particular, noting that kind of for administrative complexity, coding rules and documentation requirements, this should be standardized across all payers, and we fully support that, including for audio-only services, so we don't have unnecessary administrative complexity in the healthcare system and associated costs. In terms of billing and payment, they made additional recommendations that payment parity should continue between audio and video visits. In particular, they noted that health plans should continue payment parity for audio-video visits to ensure that audio-only telehealth remains a viable mode of care delivery for those patients who are facing barriers to care. They also continue to promote alternative payment methodologies, and that health plans should be collaborating and adopting alternative payment methodologies that enable providers to incorporate a range of telehealth services and modalities into their practices. With regards to care and access and health equity, they did really recommend that there needs to be continuity of care when patients are out of state. And they recommend that the Commonwealth should consider policy changes and interstate solutions that would enable providers to deliver telehealth to patients who live in a nearby state or who are out of state temporarily. And we fully and wholeheartedly endorse that recommendation as well. And we'll talk a little bit more about that as we talk about the legislation we proposed for this legislative session. Next, they also recommend investing in equitable access and innovative applications of telehealth. And they encourage the Commonwealth to develop policies and resources to foster patient digital literacy and increase access to affordable high-speed internet and connected mobile devices, another provision that we've been promoting as part of our digital equity legislation. We're also kind of in the place where we want, and the Health Policy Commission has supported the design of technology for inclusive telehealth delivery and the development and adoption of telehealth platforms that incorporate accessibility features to meet the varying patient needs and how this should be prioritized, such as the ability to integrate interpreter services, including closed captioning and high contrast displays for people who may have vision needs. Finally, they also support training and capacity building for clinicians and the support staff in physician practices. And they really recommend that providers are encouraged to devote resources aimed at increasing access to telehealth services in those populations that may be traditionally underserved. And one final recommendation from the Commission with regards to consumer transparency is they want to see an increase in patient education and transparency on telehealth coverage and cost sharing. To make sure that we can protect patients from receiving unexpected bills, they recommend that health plans should create accessible materials in order to educate patients on their telehealth benefits and cost sharing requirements. And they are very clear that providers should clearly disclose any billing changes in their practice and notify patients in advance of any potential cost sharing obligations in certain situations. So that's kind of the conclusion with regards to the Health Policy Commission's report and recommendations. One of the things I just wanted to share briefly is the Center for Health Information and Analysis in Massachusetts conducts an annual report on healthcare costs in Massachusetts, and they've done a really good job of providing kind of a visualization of telehealth utilization. And back in 2021, they kind of tried to give us a sense of spending on COVID-19 related services. But what they noted is that the COVID-19 pandemic obviously transformed care delivery in 2020 and 2021 with the emergency policies that were in place that we've talked about previously. And in 2021, they noted that 45% of residents reported having a telehealth visit in the state, which I think is quite remarkable, all things considered. And then additionally, when they looked at healthcare delivery transformation and thinking about telehealth spending. And when you compare the utilization of telehealth back in 2019, it was 0.01% of all spending. And then in 2020, it went up to $1.8 billion in healthcare spending. It was 4.3% of all healthcare spending in Massachusetts. Came back down a little bit in 2021. And it's $1.7 billion of spending, which is about 3.7% of all healthcare spending in Massachusetts. So just some really remarkable kind of numbers that are out there that kind of shows the growth in the utilization of telehealth and in terms of how it has impacted healthcare spending in Massachusetts. So before we kind of jump in and talk a little bit about legislation, I just wanted to talk briefly with regards to the digital divide and health equity. And to kind of level set us in terms of what the digital divide is to kind of give you a sense of a definition. And when we think about the digital divide, it's really thinking about that gap between those who have affordable access, skills, and support to effectively engage online and those who do not. And as we know, as technology constantly evolves, the digital divide that we've discussed prevents equal participation and opportunity in all parts of life. It disproportionately affects people of color, Indigenous peoples, households with low incomes, people with disabilities, people in rural areas, and older adults. And this is something that we've kind of experienced and learned quite a bit about during the pandemic. In terms of the digital divide and the three foundational must-haves to address the digital divide, it's really important and it falls upon three different things. First, we need to have internet access. Ideally, it needs to be broadband access. And it's really important to note that broadband access is not accessible everywhere in Massachusetts. Secondly, we need to have device access. And we need to assume that people don't necessarily have the devices to be able to utilize telehealth effectively. And then finally, and perhaps some cases most importantly, we need to have digital literacy. You must be able to teach folks how to use devices in order to be able to access care by way of telehealth. And these are kind of the three kind of like things that you must have, the must-haves that you have to kind of to have a foundation of the utilization of telehealth and good telehealth. I think it's extremely and critically important. So just to kind of give you some context and what we've learned and what some of the data has said, in Massachusetts, about 1 in 10 households did not have internet service when the COVID-19 pandemic arrived, and 85% of those are low income. About 1 out of every 6 gateway city households lacks any form of internet access, and it's 25% lacking internet access in households in Lawrence, Fall River, and Holyoke. There are census tracts in Massachusetts in some of the cities like New Bedford, Fall River, Lowell, and Lawrence, where 40% of residents do not have internet access. And according to the Metropolitan Area Planning Commission, about 1/3 of gateway city households do not have broadband internet speeds in their communities, which I think is extremely important. What we know is that on the positive side of things, about 268,000 households in Massachusetts have enrolled in the Federal Communication Commission's Affordable Connectivity Program, which provides monthly discounts for broadband and gives a one-time discount for devices. However, the average uptake for gateway cities participating in this program is only about 18%. And in terms of device access, at the onset of the pandemic, only about 470,000 households did not have access to a laptop or desktop computer, and 50% of those households were low income. And in gateway cities in particular, 28% of households lacked one of these devices, yet in other communities like Lawrence, Springfield, Fall River, close to 40% of those households did not have access to devices. And despite many recent efforts to get devices in the hands of folks, there's still more work that has to be done. In terms of that third pillar, digital literacy, from survey research that we've seen from the Census Bureau, from the Metropolitan Area Planning Commission, and others, about 200,000 low-income households in the state need support in building their digital skills. And as I said this before, digital literacy is probably the most important foundational support to improving access to care. And what's very interesting is that the Pew Foundation, through some of its survey work, has found nationally that 38% of the adults in the US with lower incomes are not confident in using computers, smartphones, or other electronic devices to do the things that they need to do online, including accessing telehealth care. So I think that's critically important. And another piece to know that's very interesting as well is that folks want training. They want training in basic computer skills, and particularly those who speak languages other than English. Those folks are indicating a desire for basic computer skills training as well, which I think is really important as we're having these conversations. So what are we doing here kind of in Massachusetts to address issues and advance kind of many of these advocacy priorities and really kind of put in place a more permanent framework for the coverage and reimbursement of telehealth services and address issues surrounding digital equity? We in this legislative session have proposed legislation, House Bill 986 and Senate Bill 655. It's an act relative to telehealth and digital equity for patients. It's been filed by Rep. Marjorie Decker from Cambridge and Senator Adam Gomez from Springfield. It was just heard yesterday by the Joint Committee on Financial Services, chaired by Representative Jamie Murphy from Weymouth and the gentleman, I can't remember his name off the top of my head, from the Attleboro area. And it notes that really telemedicine has made tremendous gains in Massachusetts during the pandemic, but the policies now in place regarding virtual care are only a start. And this proposal seeks to build off the gains that have been made over the past several years. And we're looking at kind of the long-term infrastructure. So this bill in particular, and probably most importantly, requires reimbursement parity for all telehealth services to be on par with in-person services by removing the sunset dates for reimbursement parity for telehealth services. That's probably the single biggest piece that folks are most interested in and want to make sure that is made clear by this legislation. Secondly, to go back to the issues with regards to continuity of care and some of those recommendations from the Health Policy Commission, this bill establishes two task forces. One, to study the interstate practice of telehealth by physicians, and two, to study the interstate practice of telehealth by other healthcare providers, including APRNs, PAs, and others in behavioral health and allied health professions. It includes language also to make clear that Massachusetts licensed providers can provide telehealth to patients regardless of their physical location. And then additionally, this legislation to address some of those digital equity issues would include language that requires the health insurance plans to develop and maintain procedures to identify and offer digital health education to enrollees in their insurance programs who may have low digital health literacy. And this is intended to assist with accessing any medically necessary covered telehealth benefits. This mirrors language that was just adopted by CMS in their final rules with regards to Medicare Advantage plans. So Medicare Advantage plans are going to have to be doing this screening and identification of enrollees to determine their digital health literacy and figure out how do we provide education for those enrollees for the effective utilization of telehealth. And we'd seek to mirror that for the commercial plans and Mass Health here in Massachusetts. Secondly, on this, in terms of addressing digital health equity issues, this legislation would require the state's Executive Office of Health and Human Services and the Executive Office of Housing and Economic Development to utilize the new common application portal that's being developed for state services for low-income programs like Mass Health and SNAP and other low-income services, to determine a method to also allow individuals to apply for the Federal Communications Commission's Affordable Connectivity Program. So we think that's a really good step and way of getting people to get the tools that they need in terms of broadband access and device access. And we think that's a really great opportunity for a program screening by way of a program that's already in place. Furthermore, and this is good news, and this is actually builds upon what we already know. The state has already, and Mass Health has already adopted coverage and reimbursement for e-consults, but we're still asking them to continue to address issues with regards to remote patient monitoring services and devices. As we've said previously, Mass Health has signaled their intent to provide guidance on these issues, and we are eager to engage in coverage and reimbursement for these services. Additionally, this legislation also requires the Mass Health Program, as we mentioned previously, to keep in place its current coverage and reimbursement policies that are scheduled to expire on September 30th. And perhaps most importantly, it also develops and directs the state's Health Policy Commission to establish two programs, a Digital Bridge Pilot Program and a Digital Health Navigator Tech Literacy Pilot Program to support expanded access to telehealth technologies and technological literacy. And just to kind of give you a sense of what those two programs are like, we're really seeking to kind of put in place grant programs for healthcare providers, human service providers, to kind of support the purchase of telecommunications, information services, and connected devices for patients. We want to really focus on those communities that have had the highest prevalence and been disproportionately affected by COVID so that they can access these services. And it's not just one thing that this grant would be able to support. It could support telecommunication, broadband and internet connectivity, could be broadband subscriptions for patients, establishment of wireless hotspots, again, remote patient monitoring platforms and services, but also tablets, smartphones, or other connected devices to help people connect to care. In addition, it could be used for telemedicine kiosks or carts for provider sites as well. And then on the flip side of that, as well as we keep talking about digital health navigator and tech literacy programs, we also want to kind of focus on establishing digital health navigators, including community health workers, medical assistants, and other healthcare professionals to be able to assist patients with accessing telehealth services. We want to focus the funding specifically to this program. So we're providing culturally and linguistically competent hands-on support so that we can educate patients on how to access broadband and wireless services and utilize these devices and platforms to access telehealth services. Again, we want to focus on those communities that have been disproportionately affected by COVID. We want to focus on the elderly. We want to focus on those who may have limited English proficiency or limited literacy with digital health tools as well. Some of the additional provisions that we're including in the legislation, we want to make sure that we're clear that this legislation would prohibit insurers from imposing prior authorization requirements on medically necessary telehealth services that would not apply to in-person visits. So make it clear that if it doesn't apply to an in-person visit, it shouldn't apply to a telehealth visit. Additionally, we want to further require insurers to cover interpreter services for those patients who may be limited English proficient and for those who are deaf or hard of hearing. We want to make sure as we're talking, and we mentioned previously, we're going to cover chronic disease management. We want to make sure that that definition of chronic disease management includes COVID-19 and its long-term symptoms, as well as the additional children's chronic diseases whose treatment is covered by Medicaid in particular. And in terms of this legislation, we also want to ask the Division of Insurance to put in place processes and procedures to kind of have automated approval systems and the establishment of electronic data exchange for healthcare providers and payers, so that at the point of sale or the point of contact with that patient at their telehealth appointment, we know how much the patient's copay is going to be when they do that at that appointment at the time of service, to make things very clear and easy for providers so that patients understand their payment obligations. So that's in a nutshell what we're working on in terms of state level legislation. I just wanted to take this opportunity right now just to talk briefly about kind of what's been going on at the federal level. And in particular, just wanted to kind of pick up on kind of the Medicare flexibilities that are going to be in place. And this is just a partial list, but probably the most important list of Medicare flexibilities that are going to be in place beyond the end of the federal public health emergency, which is now ending on May 11th. In particular, it's really important to remember that under current federal law, and it seems so antiquated at this point, but if there were no public health emergency and if the federal government hadn't passed legislation to extend these flexibilities for an additional 2 years, the Medicare program has in place restrictions on how telehealth can be used. It can only be used in certain rural areas, and it can only be used if a patient is located at a clinical site. So one of the most important things in all of this is that for the next 2 years, the use of telehealth in the Medicare program is going to waive those kind of geographic site restrictions and originating site requirements, which is extremely important. It also expands and allows for the list of practitioners that are eligible to furnish telehealth services to continue. So it's not just physicians, but also it allows us to have PTs, OTs, SLPs, audiologists are able to kind of continue to be able to provide services by way of telehealth in the Medicare program. And the Medicare program as well, additionally, will be allowed telehealth services for rural health clinics and federally qualified health centers. The federal law also delayed the implementation of an in-person visit requirement in the Medicare program, that before a patient would receive mental health services furnished through telehealth, they would have to have an in-person visit with their provider. And that requirement is going to be delayed, which we are extremely happy to see. And we're very concerned kind of with this requirement because it is not in place for other healthcare services. It is only in place for behavioral health services. And it seems to attach some type of stigma in place. And that's a real significant concern. And we've kind of weighed in with our strong objections to that. Additionally, what's probably, and most importantly, and we're glad to see kind of CMS and Medicare recognize this, is that it will continue to allow for telehealth services to be provided through audio-only communications in the Medicare program. Extremely important issue for access for those folks who may not have access to interactive audio-video technology. And perhaps most importantly as well, it also allows for telehealth to be used for the required face-to-face encounter prior to the recertification of a patient's eligibility for hospice care. Lastly, just wanted to kind of mention a late-breaking issue. I spoke to Jenny about this previously. The Drug Enforcement Agency, a few months back now, has put forth proposed rules on prescribing by way of telehealth before the end of the public health emergency. This specifically applies to controlled substances and the induction of buprenorphine. And in particular, as you can see through this chart here, with regards, if you're going to be, you have a prior in-person medical evaluation by a prescribing medical practitioner, and you're prescribing non-controlled substances, it's permitted, as you can see here, as long as you have this prior in-person medical evaluation, you pretty much can prescribe everything according to these proposed rules. Even if you referred under the proposed rules from a medical practitioner who conducted a prior in-person medical evaluation, telehealth is permitted and you can prescribe for these substances. But if you're doing a telehealth visit without a prior in-person medical evaluation by a prescribing medical practitioner or a referral from a medical practitioner who conducted a prior in-person medical evaluation, and you're prescribing a Schedule 3, 4, or 5 non-narcotic controlled medication, you can only have up to a 30-day initial prescription for that patient, and an in-person visit would be required for additional prescriptions. Similarly, those same rules would be in place for prescribing of buprenorphine as a medication for opioid use disorder. And under these rules, you could not prescribe a Schedule 2 or narcotic controlled medication by way of telehealth. So that's something that's been a flexibility that's been in place throughout the pandemic. According to these proposed rules, that would not be permitted. There were 38,000 different organizations and people who weighed in with the Drug Enforcement Agency with regards to this issue and this rule. And the Drug Enforcement Agency announced today that they would be continuing the telehealth flexibilities for the prescribing of Schedule 2 and buprenorphine that have been in place during the pandemic for an additional time period beyond the end of the public health emergency on May 11th until they put final new rules in place. So that's a good news story, but we kind of wanted to mention that briefly here as we reach the end of the presentation, but some good news that came out of the Drug Enforcement Agency today. That is the end of my presentation today. I'm happy to take any questions that folks may have. I hope I didn't go on for too long, but I know that Jenny and Maureen had said that I had an hour. So happy to stop here and take any questions that folks may have. I believe you can enter them in through the Q&A function on the screen. And I'll stop sharing my presentation.
Yes, you definitely can do that. Adam, actually, I have one question for you already. This is Jenny.
Yeah.
I wanted to ask on that digital tech literacy pilot program you were talking about.
Yeah.
Is that actually actively engaged now that maybe you could apply for grants, or is that something to come down in the future? Because I'm thinking one of the things that as a case manager on the Cape that I very much have become involved in telehealth for how to do nurse teaching and transitioning a person back into the community, as well as helping more of the elderly try to engage with their telehealth devices. I got very creative during pandemic, utilizing local libraries to do free teaching for people. It worked well. But I was wondering if they did have some grants that were available, it might be really something, I know, at least in my particular area, where it might be worth trying to put a grant together so that we have a program working for some of the elders that are really struggling with trying to learn these technical devices. I have to say, I came up with the most creative ways I could find to teach people.
Well, as a library trustee, I have to say that I'm very glad to hear that you were doing this at libraries.
Yeah.
I'm on the library board of trustees here in Arlington. But yes, two answers to your question. One, this is not in place right now. We are seeking funding through the state budget by way of amendment to put in place a pilot program, perhaps for I think $500,000 or maybe $750,000 to kind of get a pilot program up and running. Additionally, there is funding through the Massachusetts Broadband Institute. They have been doing some work in this space, and they've actually engaged a core, kind of like an AmeriCorps group of young people who are doing a lot of this work already, and that they are kind of coming to Massachusetts, or they live in Massachusetts currently, college students in particular that are doing some of this work. And they are doing a lot of this work in Massachusetts already. There's a great program in Boston through the Little Brothers, Little Sisters, Friends of the Elderly, that's doing some of this work in conjunction with Hebrew Senior Life here in Massachusetts to engage in young people to come and teach many elderly folks who live in low-income housing how to utilize devices and how they can, it's maybe not necessarily telehealth focused per se, but it is about how do you, utilize a computer, how do you access the internet, and then they kind of enroll them into the Federal Communication Commission's Affordable Connectivity Program. So there's work being done outside of the fact that we want to kind of get some of these programs in place, and the Broadband Institute is doing some of the great work and leadership in this space.
Yeah, it's a very interesting because it made me start to really think that this is something that we have to really expand past COVID because it's become such an essential part of our work as case managers to utilize telehealth. I can't tell you how many times a day I use it in my work now.
Yeah.
Okay, Maureen, I didn't know if you saw any questions that you'd like to bring up.
There are a few questions in the Q&A.
Okay, I can't access them right now, so if you could help me out with that, that would be great.
Right, or Adam, do you want to just, if you could get them?
Let's go ahead and take them.
Okay, perfect.
Here's the first one. Do you know anything about the face-to-face requirement for ordering of DME? Specifically, pre-pandemic, an in-person visit was required. During pandemic, telehealth was allowed. Will this be changing?
I think it will be. To my knowledge, I think we're reverting, especially, and I'm assuming you're speaking about the Medicare program. I think they're going to move back to an in-person requirement for ordering of DME. In particular, DME is one of those places where there's a lot of concerns with regards to fraud. This is one space in one area in the telehealth space where folks definitely have significant concerns. So I think it'll be going back to the fact that you're going to have an in-person visit required for the ordering of DME.
Right. Then the second one, do the recommendations that you spoke about include eliminating the practice of primary care providers charging fees for email portal messages as part of telehealth coverage?
So email is kind of one of those tricky spaces. And it really depends kind of what's kind of encompassed by email. And this is, again, one of those areas where the Division of Insurance has had a lot of interest because they want to understand what the implication is of an email message and who that email message is to. As we talked about, Mass Health is looking at the coverage for interprofessional consults, e-consults, and e-consults between providers is an extremely important communication form that folks think is very important in terms of providing care for patients, and that folks wanted to be able to continue to cover that. That's something that's kind of out there. Email responses to emails, it depends upon what it turns into, right? Like, is it an email and kind of how are you having a conversation afterwards with regards to it? Like, it really depends upon what it is and what you're doing. And folks have a lot of different conversations about what that means and what the implications are of email. So that's an area that I think there's going to be continuing conversations to understand kind of what we're talking about when we say email, what it's being used for.
I have one more. Do you know of any group working on digital literacy training for clients with mental illnesses?
That's a great question. I don't, Marianne, I see your question. I don't know off the top of my head any folks that are doing this type of work, but I think it's a great question, and it's clearly a space that folks would need a lot of help with and assistance with. But I think it's really an important piece, and that can be helpful, particularly because we know so many providers are providing care by way of telehealth now in the behavioral health space. Critically important. Yeah, thank you, Maureen. I think there's one more question that's in there too as well, if you don't mind me taking it, Maureen.
I don't. Go ahead.
Yeah, okay. So Fran asks, do you know if there are any changes that will be occurring simultaneous with the federal government and rural reimbursement?
Right.
In particular, I work with physicians and chronic disease patients in the Deep South who have been using telehealth by utilizing public health departments and library telesystems. So, rural reimbursement per se, I think the key thing is some things are changing in terms of rural hospitals and serving as sites. Rural health clinics are really the place that's going to be continue to be covered after the public health emergency, and reimbursement will be provided through the Medicare program for rural health clinics and federally qualified health centers. I think if there's any place that you work with, that should really be the focus, particularly, and if you haven't already focused in those spaces and working with those folks. The United States Department of Agriculture also has some programs in place that can work on some of the telehealth issues, and they do provide some resources in that space as well. So I would definitely look into those programs as well, if you haven't already looked at some of those resources too.
Any other questions? Looks like that's all there was.
All right, Adam, I'd like to take the time to really personally thank you. This was a wonderful presentation, extremely comprehensive, and really gives us good direction to move forward to, especially as we're going into that the changes with the waiver this next week. Thank you very much.
I know, you're welcome. Thank you both, Jenny and Maureen, for having me. I do really appreciate it.
We